Now that we've shown what makes up each of the lipoproteins, let's talk about what they are and what they do. So, first of all, how are they classified? The different lipoproteins are named according to their density. From low to high density, we have chylomicrons, VLDL, IDL, LDL, and then HDL. In general, higher density implies more cholesterol and proteins, less triglycerides, and a smaller size. Therefore, chylomicrons and VLDL would have lots of triglycerides and less cholesterol, while LDL and HDL would have more cholesterol and less triglycerides. By less, we mean percentage here, not necessarily amount. A chylomicron can have a bunch of cholesterol because it's freaking huge, especially after eating something like a bacon double cheeseburger or some prosciutto. This is why it's important to ask patients to fast when we order lipid panels for them. And it doesn't hurt to explain this to them to increase compliance. We'll start by talking about where chylomicrons come from. The dietary lipids and enterocytes enter the endoplasmic reticulum, where they co-assemble with a freshly translated large apolipoprotein, ApoB48. This can become a chylomicron, which also contains ApoC2 and ApoE. From the intestine, chylomicrons enter the lymphatic system and go through the thoracic duct before reaching the bloodstream. What's the main function of chylomicrons? The main role of chylomicrons is to deliver dietary triglycerides to peripheral tissue. Chylomicrons contain mostly triglycerides and only a small percentage of cholesterol. The chylomicrons meet lipoprotein lipase in the bloodstream, which releases the triglycerides. These triglycerides can be fed into muscle tissue or adipocytes. Once they've delivered most of their triglycerides to other tissues, what remains is now termed a chylomicron remnant, which transports its remaining cholesterol to the liver. We just saw how triglycerides travel from the gut to the body, so now let's look at the liver. VLDL, secreted by the liver, can drop its contents off to peripheral tissues. So given that, how do VLDL and chylomicrons differ? Although VLDL still has more triglycerides than cholesterol, it has a higher cholesterol content than chylomicrons. Another important distinction is that VLDL is produced in the liver, whereas chylomicrons are produced in the intestine. However, VLDL and chylomicrons have a similar function, which again is to deliver triglycerides to the peripheral tissues. After they've delivered some triglycerides, the VLDL and remnants are called intermediate density lipoproteins, or IDL for short. Although IDL can be taken up into the liver, it often gets further degraded, loses ApoE, and becomes LDL. Do you remember what apolipoprotein marker is found on LDL? Well, the main apolipoprotein in LDL is ApoB100, and its function is to transport cholesterol from the liver to peripheral tissues. During the transition from VLDL to IDL, lipoprotein lipase was used to allow triglycerides to be delivered to the peripheral tissues. Hepatic lipase plays a similar role and degrades some more triglycerides from the intermediate density lipoprotein to make it low density lipoprotein. Therefore, in LDL, mostly just the cholesterol remains. Therefore, in LDL, pretty much the only thing that's left over at this point is cholesterol. LDL and its cholesterol are taken up by cells via receptor-mediated endocytosis. This means that cells need to express LDL receptor in order to get cholesterol from LDL. We'll talk about this more in a minute when we go through the dyslipidemias. Like many things, LDL isn't inherently bad. In fact, without it, you'd be in serious trouble. It's just bad if you have too much of it. In other words, if found in excess, LDL may be thought of as the bad or lousy lipoprotein. This is because it transports cholesterol from the liver to the rest of the body. In large arteries, LDL can get oxidized and trapped in vessel intima. Subsequent oxidation of LDL can cause macrophages to accidentally recognize it as a pathogen, so they endocytose it and become foam cells, which is the beginning of atherosclerosis. You'll hear more about atherosclerosis in the cardiovascular section, but just realize that high LDL levels contribute to the formation of atherosclerotic plaques. Our last lipoprotein is HDL, which can generally be thought of as good cholesterol. Remember that a high HDL is usually healthy. This is because HDL basically has the reverse function of LDL, since it transfers peripheral cholesterol, including the cholesterol in atherosclerotic plaques, back to the liver. HDL is produced in the liver and in the intestine. When HDL is created, its core is mostly empty, but its membrane has lots of proteins, which gives it a high density. As it travels through the circulation, it picks up cholesterol from the body, causing it to fill up and expand until it ends its journey at the liver. Once the cholesterol gets dropped off at the liver, it can be sent to the intestines as bile salts, or get repackaged into VLDL and sent back to the body. Which apolipoproteins are found on HDL molecules? HDL acts as a repository for apolipoprotein C and E, which are needed for chylomicron and VLDL metabolism. Okay, flash quiz time. Which organs take up low-density lipoproteins from circulation? And what receptors are used for this? I'll give you a sec. Well, the liver and peripheral tissues both have receptors to uptake LDL from circulation. This receptor is specifically LDL receptor, which recognizes the B100 apolipoprotein on LDL. Let's talk about things that can go wrong with lipids and lipoproteins. A standard lipid profile measures LDL, HDL, total cholesterol, and triglycerides. And remember, this should all be taken during fasting conditions. A dyslipidemia is any significant difference from normal values in a lipid profile. High LDL and low HDL are both well-established risk factors for atherosclerosis and coronary artery disease. Before we move on, it's critical that you understand the lipoproteins that we just went over. So, mini flash quiz. Do you remember which is the quote-unquote good and quote-unquote bad cholesterol? Hopefully you remember that high HDL is protective because it moves cholesterol from the body to the liver to be excreted as bile salts, and high LDL is bad because it may lead directly to atherosclerosis formation. Alright, let's talk about the hyperlipoproteinemias. Type 1 dyslipidemia, also known as hyperchylomicronemia, is defined as an increase in chylomicron levels. This results in elevated levels of triglyceride and cholesterol in the blood, although it mostly affects triglycerides. Hyperchylomicronemia is caused by an autosomal recessive deficiency in lipoprotein lipase, or by a defective ApoC2, which is the cofactor needed for lipoprotein lipase. How can hyperchylomicronemia present clinically? Well, this can result in pancreatitis, hepatosplenomegaly, and xanthomas. Xanthomas are basically accumulations of cholesterol. Think of them as tendinous plaques. You can see an example of xanthoma tendinosum here in this picture. It's important to note that hyperchylomicronemia does not necessarily increase the risk of atherosclerosis, since there aren't high levels of LDL. Type 2A dyslipidemia is known as familial hypercholesterolemia, and is characterized by increased LDL and cholesterol levels. It's caused by an autosomal dominant mutation that results in absent or deficient LDL receptors. Without the LDL receptors, LDL can't be taken up by the tissues, and therefore it accumulates in the bloodstream, eventually becoming deposited in blood vessel walls. LDL carries cholesterol throughout the body, so cholesterol is increased as well. This leads to atherosclerosis and vessel injuries such as the one shown in the picture. This can also cause tendon xanthomas and corneal arcus, which is the pale arc of cholesterol you can see in these images. Note that these are similar to arcus senilis, but seen in much younger folks. However, these deposits generally begin at the top and or bottom of the iris and fill in until they cover the whole circumference. Arcus senilis is usually all around the iris. In familial hypercholesterolemia, there is also usually a thin, clear section separating it from the sclera. Type 4 dyslipidemia, or hypertriglyceridemia, is also an autosomal dominant disorder. So if you're keeping count, we've had an autosomal recessive disorder, an autosomal dominant disorder, and now another autosomal dominant disorder. Hypertriglyceridemia is characterized by high hepatic production of VLDL molecules. Do you remember what VLDL molecules are primarily made of? VLDL contains mostly triglycerides, so you'll see an increase in triglyceride level on a lipid profile. This most notably causes acute episodes of pancreatitis, just like we saw in type 1 dyslipidemia. Well, that's all for the hyperlipoproteinemias. Okay, flash quiz time. A 35-year-old woman has a myocardial infarction. On exam, she has Achilles xanthoma. What do you think the defect is, and what might the blood work findings show? This woman likely has type 2A familial dyslipidemia, also known as familial hypercholesterolemia. This disease usually results from absent LDL receptors, so LDL and cholesterol levels are increased in the bloodstream. The high LDL can lead to atherosclerosis, which probably contributed to her heart attack, while her high cholesterol levels can be seen here as Achilles xanthomas. Since the patient has a heart condition and xanthoma formation, it can be assumed that she has high cholesterol levels, which are a trademark of type 2A dyslipidemias.